Good morning. Nice to see you. My name is John McDonough. I'm from Harvard University, the School of Public Health. I was asked to provide some expert commentary on the proposal for the PVA, and so that will be the substance of my remarks. I don't have a PowerPoint. I will instead just deliver them to you. So I did this work in collaboration with two colleagues from the Harvard Chan School of Public Health. First is Professor Rafat Atoun, who is formerly of the Imperial College in London and is a long-time expert in global health systems, including health technology assessment and other related proposals. And I also worked with Dr. Elizabeth Seeley, who is an expert in pharmaceutical reimbursement policy at the School of Public Health. Both are very familiar with HTA, and so the three of us collaborated together. My field, I have done work in global health reform, but most of my work has been, as mentioned, in the United States, in the state of Massachusetts, from where I was born and have lived most of my life, and also from time in Washington, D.C., when I worked in the United States Senate on the writing and passage of the Affordable Care Act, which you probably have heard as Obamacare. And by the way, if you'd like to talk about Donald Trump, I'll be over here later on. So first of all, I'd like to congratulate Professor Danko for his excellent proposal and for his collaborators as well. We, Drs. Atoun and Seeley and I, spent considerable time discussing, reviewing, and going over this proposal. We all agreed that the PVA proposal is smart, thoughtful, well-prepared, and incorporates in innovative ways all of the essential components that one would want to see in an HTA proposal. PVA is a unique product. We haven't seen anything quite like it in the HTA world, but it is very much a product of the HTA approach in a way that is attempting to fit with the needs of a nation and an economy and a regulatory system such as Serbia's. HTA is, of course, not a new idea. It has been around for a long time, since the 1960s and 1970s in the United States. Many other countries have long experience with this. We agree that the 5 criteria that Professor Danko puts forward are appropriate, including the added clinical benefit, the international funding and assessment references, the alignment with national health policy, social and ethical considerations, and the budget impacts. So all of those we think are very appropriate and are appropriately considered as they're broken down with the various criteria that Professor Danko described. My colleagues and I have 3 related observations and comments to make in particular with them. I would put these in the category of commentary, not so much criticisms, but considerations moving forward if there were to be the implementation of a plan such as this in Serbia or in any of the other nations that are looking at ways to do it. So first is a sense that particularly at the start, at the launch of an initiative such as this, it is possible, even though the 5 criteria are particularly scaled down, that it may in fact be somewhat too ambitious for a nation getting into this. It is not accidental that even though HTA ideas and proposals have been around for many years, that there are in fact so few nations in the categories of Serbia that have embraced it and used it, and that there might need to be a process of phasing in such a system such as this, because it will take a learning curve, it will take time, it will take some adaptation for Serbia or for any nation to implement this whole thing, as much as it sounds fairly simple and straightforward. So that is the first thing. Second thing is that it needs to be aligned with a fuller assessment of the government's administrative capacity to implement and to manage this system. It is something that ministries of health in Serbia and elsewhere do not have the full capacity to do. And even though it is simpler and more straightforward, it will require significant time. And so the capacity of the government to implement this and put this forward in an effective way is something that really needs to be considered as part of this. Also because there are so many other competing priorities within the government, so many more competing demands. And so how this fits in a way that will work in the Serbian health system is something that is very important to keep in mind. There was in Professor Danko's report a conclusion that an appropriate target for this would be 3 months for the consideration of a new therapy. I think my colleagues at the School of Public Health thought that that is perhaps ambitious. Certainly not in terms of the ability of one person to, or several people or a small group to come together and do it, but to put it through the entire political process of the government decision-making is probably overambitious, but certainly an admirable target and place to aim for in terms of a goal. Third, and finally, though the hope is that the consideration of innovative therapies and coming up with a streamlined process for their consideration and a decision on adoption or non-adoption would happen quickly and in a way that particularly highlights those innovative therapies which are both quality enhancing and cost reducing. The real world experience with new therapies is that they tend not to be. And so there does need to be, and there is an added particular weight to the budget considerations, but there needs to be a balancing process in terms of the consideration of the priorities for money for new therapies and the priorities for all of the other things that are challenging this government. And I think we've seen from the Economist report that there are many challenges facing this system right now. And clearly, the innovative therapies is an important one, and it is not the only one. And so it needs to be kept in that context and understood. It does not make sense to look at innovative therapies simply in isolation from all of the other needs in the system. That isn't to say that it should be put in the garage, that it should be ignored. It is appropriate for people to come together, as is being done today, and to examine and talk about and explore this, and it also needs to be seen in context. Governments have many important challenges, including this one, and so it's important to keep that in mind. But these observations that I and my colleagues make are offered with admiration and support for the fine work that Professor Danko has done and presented to all of you. We think his work reflects conclusions from many quarters that the people of Serbia could be well served by, particularly in a process that is open, abundantly transparent, and publicly accountable in terms of that process. But it's important to understand that as you make it open, as you make it accountable, as you make it accessible to the broad public, that also slows things down. It makes it more difficult. Transparency doesn't make it easier to get things through. It makes it more challenging, hopefully in a way that provides a better conclusion to your process, but certainly not something that makes it easier along the line. It is obviously much easier for ministry officials to sit together to decide yes, no, and they can do it very quickly and come out with a fiat. It is better to do it in a publicly accountable and transparent way. That doesn't make it easier necessarily. That often makes it much harder. There's a fundamental dilemma that is introduced. Forgive me while I take a drink. I hope it's not alcoholic. Maybe I hope it is. Thank you for your indulgence. It seems to me, looking at the various commentaries and the materials that I looked at and studied and reviewed before I came here, that there's a fundamental contradiction regarding innovative therapies in Serbian society today, which is that if you look over the past 10 years, there has been a noticeably slow introduction of new therapies, as Martin admirably put forward with his helpful and illuminating data. And yet at the same time, and it wasn't in this, but it's available in other reports, the cost of pharmaceutical spending in Serbia has been going up at a pace over the past 10 years significantly greater than the rate of growth in other West Balkan nations and in the EU as a whole, in comparison with markets that have been allowing many, many more innovative therapies into the market. So it challenges and tests the fundamental strategy that the government has been following for the past 10 years of allowing very few new pharmaceutical products into the market in hopes that that would lead to a moderation in healthcare spending. Clearly that has not occurred, and clearly we have seen the opposite from it. Very few new medications coming in and pharmaceutical spending going up at a pace far in excess of what we're seeing in other countries where the markets are more open. I haven't seen clear evidence to explain that contradiction, but it seems to me the contradiction is glaring and something worth appreciating and understanding as you all figure out how to move forward in this. At the same time, it's also worth noting, and this was documented by the excellent presentation from the patient advocate. There are many, many medications and therapies that are now available in other societies that make meaningful, real, consequential difference, both in terms of quality of life, patients' health, prevention and elimination and treatment of illness, and in many cases, some of them actually significantly cost-reducing for the healthcare system as a whole. In critical areas, rare diseases, cancer, HIV, MS, hepatitis C, that are very available now in other societies that have been, for the most part, kept out of the Serbian market. And that is important and telling, and something I think that people in Serbian society don't necessarily appreciate if they're not directly connected in some way to some of these particular illnesses and diseases. So that is an important consideration, and all the more reason to give Professor Danko's PVA assessment tool, I think, a fair hearing and serious consideration. I would just add, and this is the conclusion of one of my other colleagues at the Harvard School of Public Health, Dr. William Shao, who has been consulting with governments on health system reform and health system improvements for the past 40 years. A fundamental challenge in health policy in most nations around the globe, very much the United States and very much other countries. You know, in the United States, we spend more on health care than the cost of the health systems in most other nations combined. We often wonder how people can be worried about costs in other societies when we spend so much. But it is a fundamental challenge that in societies all across the globe, that the demand for medical care and for medical services and the demand to increase and pay more for those services leads in most societies to a rate of growth of healthcare spending that significantly exceeds the underlying rate of growth of the economy. And then that creates an intense contradiction and competition within each society as more is invested in medical care and then less is available to other important societal needs, whether it is education, quality housing, transportation, infrastructure, many things that actually have more to do with the health of societies than does the investments that we make in medical care services. So that is a constant contradiction that every society deals with. The other piece that I would just put out that I think is very evident in the United States, very evident in Serbia, it comes down to one word in terms of why these issues are so difficult to resolve. And the word that it comes down to is trust. T-R-U-S-T, trust. there is, across healthcare, a lack of trust. Government doesn't trust the drug industry. Government doesn't trust hospitals. Government doesn't trust physicians. Government doesn't trust pretty much anyone. Pharmaceutical companies, hospitals, physicians, all have to deal with each other, but deal with each other in ways that prevent the kind of collaboration, and then patients, for very legitimate reasons, have trust about who is making decisions, for what purpose, under what considerations. It's a fundamental problem that all health systems face, and in particular we see in Serbia as well, particularly relating to the documented high levels of corruption in the system. And so the question then is, how fundamentally do we get at the issue of trust? How do we move forward and get beyond it? You know, it's one thing if your car needs to be fixed and you take it to the garage to get repair, and your instinct is to trust the auto mechanic that he will do the right thing at a reasonable cost, and then you learn that he didn't. And your trust with that person is broken. And once the trust is broken, it's very hard to repair, but then if I don't like the result, I can go to another garage someplace else and hope I get a better deal. But it's different in the healthcare system because we're stuck with each other. We're not going away. We're here. The different stakeholders and players, the faces and the people may change, but the fundamental tensions stay the same. So I believe there's only one direction forward that really gets at the issue of trust. While we argue about who's doing what, who's treating whom fairly, that the fundamental focus of the conversation has to be about patients, about consumers, about citizens, as the starting point for the consideration in terms of what makes sense, what doesn't, what is a priority, or what is not a priority. I think what you're talking about here today, with the good work that has been done, is very much focused on getting at some of these lingering important systemic issues. I think that the PVA instrument is a good, nice step forward for the consideration for the Serbian health system to make improvements in this while it continues to deal with a host of other very pressing, compelling, and important challenges. And I wish you all well, and hope for success in terms of taking this system, making it something that can work for Serbia as you address all your other challenges. Thank you very much.